Good evening to all of you. I am Dr. Fahad Afzal. I'm a consultant medical oncologist at JustLo, and today I'll be discussing about colorectal cancer. At the outset, I would like to thank the entire group from Hetero for giving me this opportunity to talk about this very much important topic, colorectal cancer, especially in the month of March, which is the Colorectal Awareness Month. So as we know, colon and rectum is the distalmost part of the digestive system that is composed of the large intestine and the rectum. And any cancer arising from this site is called a colorectal cancer. So the cancer begins in the form of a small polyp or an outgrowth which begins from the gland, and then slowly the polyp enlarges and ultimately gets transformed into a malignant tumor, that is cancer. Why is this such a pressing topic? So if you look at the statistics in India, colorectal cancer is one of the 5 most common cancer in terms of incidence or the number of new cases. In the year 2020 alone, 65,358 new cases of colorectal cancer were detected. That is almost 4.9% of all cancers. This risk of colorectal cancer in India is especially high in Northeast population and in South India. And among the gender, there is also disparity. Males have considerably higher risk of developing colorectal cancer, almost 2 times higher when compared to females. In the US, the story is even worse. Colorectal cancer is the second leading cause of cancer-related death in United States. However, despite this fact, there are more than 1 million survivors of colorectal cancer in the US, and this is only because of early screening. At least 60% of death due to colorectal cancer can actually be prevented by early screening. So let us know what are the risk factors for developing colon cancer. Now, these risk factors can be modifiable. That means something that is in our control that we can change, such as physical activity by making sure that we walk at least half an hour for at least 5 days of a week, or making sure we don't end up being obese. Obesity is one of the risk factors for colon cancer. Making sure that one has a healthy, balanced diet, avoiding smoking, and avoiding all the risk factors for developing type 2 diabetes mellitus. These are the risk factors that is in our control. Besides this, there are certain risk factors which are the non-modifiable ones, which is not in our hands and as a risk factor for colorectal cancer. These are increasing age. As the age advances, the risk of colorectal cancer also increases. Second is family history of colon cancer. Any first degree or second degree family member who has been diagnosed with colon cancer, especially before the age of 50 years, is at very high risk for developing hereditary colon cancer, that is the familial type of colon cancer that runs in the family. Also, any personal history of polyps or previous colon cancer predisposes that individual to develop colorectal cancer in the future. Also, inflammatory intestinal conditions such as IBD, ulcerative colitis, Crohn's disease are also risk factors for colorectal cancer. Now, how do we know what are the early signs and symptoms of colorectal cancer? The first and foremost is blood in your stools. So, this blood may be uh, obvious, visible blood in the form of drops or streaks of blood, red blood, or it can be altered blood, which is called melena, which is dark, tarry, black, or it may be occult blood. That means which is not visible to the naked eye, but is only detected when a stool for blood is sent. A result of this is a low hemoglobin. So many a times patients present with anemia of unknown origin. On evaluation, it turns out to be due to blood in the stools that is secondary to colorectal cancer. The next sign is loss of weight. Unexplained and unintentional loss of weight is also a sign not just for colorectal cancer but for many other malignancies, especially of the gastrointestinal tract. The other symptom is a vague abdominal pain which does not settle with common painkillers with a normal sonography of the abdomen. And then comes the most important, that is changes in the bowel pattern. That means constipation alternating with diarrhea, weeks of diarrhea followed by weeks of constipation unexplained. This is also an early sign of colorectal cancer. So coming to the first sign, that is blood in the stool. So what does this tell you? That there is a tumor in the colon which is now bleeding, and that blood is coming out in the form in mixed with the fecal matter. 37% of patients actually have blood in the stools if they are having colorectal cancer. As a result, patient also complains of exhaustion secondary to anemia. There are symptoms related to anemia like breathlessness, palpitation, etc. The next symptom is changes in the bowel habit. As I had earlier described, diarrhea alternating with constipation or a feeling that the bowel has not been emptied completely. This is also a sign of colorectal cancer. Then there is weight loss. Significant weight loss is defined as weight loss of 5% of your body weight over a period of 6 months, which is unintentional without any strict diet or weight loss program. This is can be a sign of colorectal cancer. And then there can be a vague abdominal discomfort or symptoms such as frequent gas related pain, bloating, fullness, cramps, etc. can also be early marker for colorectal cancer. Anemia, as I previously said, bleeding from the tumor can lead to blood loss through the stools, and this can drop the hemoglobin levels, and that can cause iron deficiency anemia. So unexplained iron deficiency anemia up to 23% of patients with colorectal cancer, that is one fourth of patients present only with anemia. Then there is fatigue, which can be secondary to anemia or loss of appetite. So now, how do we screen colorectal cancer? So there is the fecal immunochemical test, also called the FIT. Here, the stool is tested for blood with a swab on the bowel movement and then placed on the card. This has to be done once in a year. It has a specificity of 96% and a sensitivity of 73%. Then there is a more commonly available the GUIAC fecal occult blood test, or the GFOBT. This is also done in a similar manner and should ideally be done once a year. It detects presence of any occult blood in the stools. The specificity is 92% and the sensitivity is 70%. Then comes the more higher end stool DNA. This checks for any abnormal DNA or blood in the stool. If this test is done once every 3 years is sufficient. It has a higher sensitivity of 92% but a decreased specificity. That means there can be other causes of a positive stool DNA for blood. Then there is double contrast barium enema. Here, air and barium together are pumped inside the rectum via a pipe, and this solution then shows up on the X-ray. This has to be done once every 5 to 10 years. It has very low sensitivity and specificity. Then there are the invasive tests, the invasive screening tests for colorectal cancer, such as colonoscopy. Colonoscopy is a very simple and safe procedure where the endoscopist or the gastroenterologist uses a long tube which has a light and camera at the end, which is inserted through the rectum, and the entire large intestine is visualized directly right till the end part of the small intestine. So this has to be done once in 10 years or once in 5 years if there's high risk of colorectal cancer. This has a very high sensitivity of 95% and a specificity of 86%. This has an added advantage that if there are any abnormal polyps, then that can be biopsied or checked for testing for any cancer cells at the same sitting. Then there is flexible sigmoidoscopy. This is an abbreviated version of colonoscopy. Here, instead of visualizing the entire large intestine, only the terminal part of the intestine, that is the sigmoid colon, is visualized. It detects polyps that are present in the sigmoid colon, and this has to be done once every 5 years along with the stool test, because proximal cancer, that means cancers in the early part of large intestine, may be missed with a sigmoidoscopy. Then there is a new entity called a virtual colonoscopy. Here, there is no pipe or no camera which goes through the rectum. Rather, a CT scan is done, but the machine has a certain software which can reconstruct the images in the form of a colonoscopic video, and that can be used in order to screen for any abnormal polyps, and this can be done once every 5 years, but it has low sensitivity and specificity, and that's why not very commonly done. Now coming on to the first test that we spoke about, that is the fecal occult blood test. So this checks the stool samples for any hidden or occult blood. Stool DNA will identify any DNA changes in the cells of the stool sample. It is a new method for screening colon cancer. Then, as I discussed, there's a double contrast barium enema where air and contrast is injected, and then the X-ray picks up whether there is any filling defect, and then that particular filling defect is further investigated to check if there's a tumor at that particular site. There is sigmoidoscopy, where a diagnostic test is, which is a diagnostic test to visualize the terminal part of the large intestine. Then there is the entire dedicated colonoscopy, where the entire large bowel is visualized with the help of a long tube which has a light and camera attached at its end. And then this is the virtual colonoscopy. So as we know, once the diagnosis of colon cancer is established, the next step is to stage it. So staging is done depending on the location of the primary tumor and whether that tumor has spread to regional lymph nodes or distant organs, that means liver, lung, brain, bones, etc. Based on that, the colorectal cancer is divided into 4 stages. Stage 1 is said to be there when the cancer is limited to only the mucosa. Mucosa is the innermost lining of the colon, and just below that, that is the submucosa. Stage 2 is if it has gone further deeper into the serosa. Serosa is the outermost lining of the large bowel. It is said to be stage 3 colorectal cancer if this cancer has gone out of the bowel to the nearby regional lymph nodes. And it is said to be stage 4 if the cancer has gone even beyond to distant organs such as liver, brain, lungs, etc. So if we look at the various treatment modalities for treating colorectal cancer, we have surgery, then there is radiation, then there is chemotherapy, then we have targeted therapy, and finally the new kid on the block, that is immunotherapy. So treatment is as per the staging. For very early cancer, where it has not even breached the innermost lining, it is called stage 0, and the treatment is as simple as a polypectomy, wherein colonoscopically the polyp is just removed, as simple as that. However, if it is stage 1, where the tumor is involving the mucosa and the submucosa, then surgical removal of the tumor along with the regional lymph nodes, even when it is not involved, is the treatment. Sorry. Stage 2 colorectal cancer is treated with surgery or surgery followed by adjuvant chemotherapy, depending on whether the regional lymph nodes are involved or not. If there is stage 2 rectal cancer, then along with this we add radiation therapy to the chemotherapy, and then the surgery is done. If it is stage 3 colorectal cancer, wherein regional lymph nodes have also been involved with the tumor, then the treatment is surgery followed by adjuvant chemotherapy. If it is rectum, then we give radiation and chemotherapy, then comes surgery. For stage 4, one may do surgery if the tumor is resectable along with radiation therapy. But however, the mainstay of treatment remains systemic therapy in the form of either chemotherapy or immunotherapy or targeted therapy, depending on the histology of the tumor, that means the type of the colorectal cancer. So coming to the first modality, that is polypectomy. This treatment is reserved for very early colorectal cancer, that is stage 0, when we know that the tumor is just limited to inside the cell, and it has not even reached the basement membrane. So polypectomy is the removal of the abnormal growth of tissue, which is called a polyp, and it can be done with this excision snare. Next comes the laparoscopic surgery. As we know, stage 2 and above are treated with entire resection of the bowel along with the regional lymph nodes. The various approaches done for this is open approach, which is not routinely done nowadays, or laparoscopic approach, or the newer robotic approach. In GI surgeries, robotic surgery is not done as widely as laparoscopic surgery. In laparoscopic surgery, there are small holes called ports that are inserted into the abdomen. One port has a laparoscope which visualizes, the other has a snare, and the third one has the light. So in laparoscopic colon resection surgery, a small incision is done, and through that incision, fiber optic cameras are introduced. So based on where exactly in the large bowel the tumor has arisen, whether it is on the right side, that is the ascending colon, or the transverse colon, or on the left side, that is the descending colon, or in the sigmoid colon, we can have the various surgery that can be done is a right hemicolectomy, or a left hemicolectomy, or a transverse colectomy where the entire transverse colon is removed, or a sigmoid colectomy where only the sigmoid colon is removed, a subtotal colectomy, or a ultra low anterior resection, which is done for low colon or high rectal cancer. Then we have an entity called colostomy. Many a times the sphincteric control of the body, where we know we have a control over passing stools, is lost because of the surgical resection. In such patients, a colostomy has to be created. That means an artificial stoma or an opening on the skin of the abdomen where it mimics the natural bowel movement and acts as a exit for fecal matter. This colostomy bag can be permanent or temporary depending on whether a resurgery can be done to establish connection between the tumor site and the normal bowel. Next comes the chemotherapy, which is a very important modality for treating colorectal cancer. So there are various types of chemotherapy usually given in the form of combination. So we have a combination regimen called FOLFOX, which is a 2-day continuous infusion of chemotherapy drugs such as 5-FU, leucovorin, and oxaliplatin, which is given through the IV or the intravenous route for 48 hours continuously. Then we have a combination of oral chemo with IV chemo called CAPOX, where a tablet capecitabine is given along with injectable oxaliplatin. We have modifications of these regimens such as FOLFIRI and FOLFOXIRI, which depends on how aggressive the tumor is and the general condition of the patient. So chemotherapy may be given after surgery to remove or eliminate the remaining tumors which are present either in the circulation or at the surgical bed. In rectal cancers, chemotherapy and radiation therapy is usually given before surgery to reduce the size of the tumor so that it is easier for the surgeon to resect and even easier for the patients to retain their normal defecation after surgery. Next, we have targeted therapy. As the name suggests, the medicines have an actual target which is in the form of certain receptors present on the tumor. So these agents go and specifically get themselves attached to these receptors and then break down the tumor cells. The most common targeted therapy that we use is bevacizumab. It is an injectable drug and now very commonly available in India, but at a very costly price. Then we have EGFR inhibitors, which acts in a similar mechanism. Here we have an agent called cetuximab, which goes and attaches to the EGFR receptor that is present on the tumor cells and then enters the cell and causes permanent damage to the tumor. The new kid on the block is immunotherapy. Unlike chemotherapy and targeted therapy, here the agent or the medicine does not go directly and to the tumor cell and kills it. Rather, it goes to the body's own immune cells, that is the T cells, and stimulates it to generate an anti-tumor effect. As a result, the side effects are almost not there, and it is more easier to give. The tolerance is good and it can be given to even elderly patients or even bedridden patients without worrying about the standard toxicities associated with chemotherapy or targeted therapy. We all know that prevention is always better than treatment or cure. So how do we prevent colorectal cancer? So first and foremost, because it involves the gastrointestinal tract, one must eat a very healthy diet which is rich in fruits, vegetables and whole grains. Also, because there is a familial predisposition, one should evaluate first degree relatives if there are any members in the family who had been diagnosed with colon cancer at a very early stage, this should arise any suspicion of having familial colon cancer. Being physically active and maintaining a healthy weight are the other ways by which colorectal cancer can be prevented. Quitting smoking and alcohol can also drastically reduce the risk of colon cancer. Now, who should be screened? So, for an average risk patient who does not have any of the risk factors, including any family history of colon cancer, above 50 years of age, every person should undergo some screening test. It can be fecal occult blood, or colonoscopy done once in 10 years, or a sigmoidoscopy done once in 5 years. These patients have no history of colon polyps, no family history. Despite that, after the age of 50 years, they need to do colonoscopy or any of the screening tests. Then the incidence of colorectal cancer in younger adults, that is less than 50 years of age, has been increasing at a rate of 2% every year since 2003. So now the average, it has been suggested that the average risk screening age instead of 50 years should now begin at 45 years. So what about those who are at a higher risk? So these are uh, person who have a family history. That means one or more than one first or second degree relative who has been diagnosed with colorectal cancer. These healthy, so-called apparently healthy people should not wait till the age of 45 or 50. Rather, they should start getting themselves screened from the age of 40 onwards, and they should do a colonoscopy once every 5 years instead of 10 years, in view of their higher predisposition to develop colon cancer. Also, those who have a personal history of any advanced polyps or inflammatory bowel disease or previous history of early colorectal cancer, they belong to the high risk category and should get themselves screened more frequently. So summarizing, colorectal cancer is a common but very treatable cancer. The average screening age is 50 years and above till the age of 75 years. Here, getting annual screening or once in 10 years endoscopy, colonoscopy can drastically reduce the incidence of developing advanced colon cancer. Family history and personal history plays a very important role in deciding your risk for developing colorectal cancer. Screening and colonoscopy prevents and even treats the cancer, because through the colonoscopy we can actually remove any precancerous polyp, and even if it is an early cancer, it can actually be treated with a colonoscopy alone. A healthy, high fiber diet, exercising regularly, and avoiding alcohol or tobacco in any form can lower your risk of developing colorectal cancer. And this colorectal cancer screening rates must be optimized to reach the aspirational target of reducing the incidence by more than 80%. Only then we would consider that the screening in a particular population has been done adequately. So if you are above the age of 50 years, and even if you or anybody in the family has never had colorectal cancer or any of the risk factors, you still need to get yourself screened by either a stool occult blood test every year, or a sigmoidoscopy or a colonoscopy done once in 10 years. That brings the end to my presentation. Thank you for being a very patient audience.